Profesor Hugh Taylor, es un gran placer tenerlo hoy aquí para esta reunión y hacerle esta entrevista. Quiero presentar al profesor Hugh Taylor, quien es profesor de obstetricia, ginecología y ciencias reproductivas en la Universidad de Yale y es uno de los más importantes autores de publicaciones sobre endometriosis, sobre fisiopatología y todo esto tratando de entender gran parte de sus artículos donde hablan en la actualidad de que la endometriosis es una enfermedad sistémica, inflamatoria y que requiere obviamente una atención especial dado que está asociado con muchas comorbilidades. Profesor, nos interesaría conocer su experiencia en función de la publicación que hizo en el año 2021 en el Lancet acerca de la que la endometriosis es una enfermedad sistémica. Y en esa línea me interesaría su opinión acerca de los tratamientos médicos, dado que en Argentina, y como hemos visto que esto ocurre en gran parte del mundo, el acceso a la cirugía no es una opción disponible para toda la población. Y muchos colegas tratan a esta enfermedad o a la sospecha de esta enfermedad con anticonceptivos, gestágenos y también en la actualidad con antagonistas del gen RH y también puede ser con agonistas con terapia DUAC. Para entender todo esto es importante entender la fisiopatología de la endometriosis, entender la actividad aromatasa, la resistencia a la progesterona y nos gustaría saber, en su opinión, cuál es el mejor tratamiento teniendo en cuenta diferentes tipos de pacientes, dado que no es lo mismo una paciente adolescente, una mujer en edad reproductiva o una que está cercana a la menopausia.
Well, it's variable. I mean, as you said, there are different types of patients with endometriosis, different phases of life where they may need different therapies. Somebody trying to get pregnant is obviously not going to be a candidate for medical therapy. We don't have a medical therapy that improves fertility. Um, the, uh, the different types of medical therapy, too, have to do with different types of patients being more sensitive to some. Progestin resistance is a major concern, so progestins don't work in all patients. We often will start, though, with an oral contraceptive, not because it's the best and most comprehensive that treats everyone, but because they're easy and inexpensive. They're very acceptable, very few side effects, are quite well tolerated by most patients. But yet, probably a third of them don't respond because of severe progestin resistance. And then up to a total of 50% don't stick with oral contraceptives because they do have side effects. We just published a paper in Fertility and Sterility in the last couple of months looking at women with endometriosis having an enhanced sensitivity to progestin-related side effects on an oral contraceptive. So they probably only work about half the time. You combine the progesterone resistance where they get no pain relief and intolerable side effects. They're not great. Now, for those who have no pain relief, sometimes I'll go to higher doses of progestin. Progestin resistance is not all or nothing. Some patients have greater degree of progesterone resistance and will respond to much higher doses of progesterone or other progestins. But there are some that are completely progestin resistant. And as I mentioned before, some have considerable side effects from the progestin. Again, women with endometriosis are often more sensitive than others to progestin-related side effects. So that often isn't a viable option if somebody has side effects, or they may have complete progesterone resistance, failure to respond to progestins, and you need to go to something else. In the old days, we always used to go to the GnRH agonists. Those are second-line therapy. While endometriosis is complex and can be progestin resistant, it always needs estrogen to grow. Even postmenopausal endometriosis is making its own estrogen. So you never see endometriosis without some estrogen feeding it. So GnRH agonists work fairly well, but they're injectable. They're slow to take effect because of the initial flare effect. You have to stimulate the receptor before you downregulate it. You may see 2 weeks or so before you really even start to see any symptom improvement. So they're relatively irreversible. It may take months for the GnRH agonist to fully clear the system. So the GnRH antagonists have really replaced agonist as the next treatment after birth control pills. We use them because, again, they are oral, so more patient-friendly. Patients like them better. For somebody wanting to conceive or hesitant to take a new drug who wants it to reverse very quickly, these drugs reverse rapidly. Within about 24 hours, the effect is dissipated and estrogen starts to recover. And the immediate onset of action. They block the receptor instantly and very rapidly take effect. Again, you can lower your estrogen levels within about 24 hours or so with the GnRH antagonists that we have available. So those have rapidly become the second-line therapy for most women with endometriosis who either don't respond to a birth control pill or have significant side effects on a birth control pill.
¿Usted cree, doctor, que los antagonistas son más efectivos en el tratamiento antiinflamatorio que los gestágenos en el tema de la endometriosis?
I think is better that, yes, there are estrogen-driven inflammation. I think we still need to think about combining either of those treatments with a nonsteroidal anti-inflammatory, and I think immune modulation of endometriosis is where the future is. I think there'll be a lot more therapies that look at modulating the immune system. We're working on some of those now. But I think either with progestins have an immunosuppressive component, but estrogens drive some inflammation as well. So giving more progestins or lowering estrogens both will help with the immune system, which is a major component of endometriosis. But I think future therapies will be looking more at modifying the immune system as well.
El año pasado, en julio, usted publicó junto al profesor Jacques un artículo que es sumamente útil para nuestros colegas, dado que desarrollan algoritmos para el tratamiento tanto de miomas y endometriosis en mujeres con y sin deseos de embarazo. ¿Qué nos sugiere acerca de esto?
GnRH antagonists work very well for endometriosis, for adenomyosis, and for fibroids. The rapidity of onset is so fast. With fibroids, there's a new paper coming out from Jacques' group looking at how quickly these GnRH antagonists can act. And within days, you can stop having menstrual bleeding in a woman with fibroids. Really amazing. The efficacy and rapidity. Now, of course, with GnRH antagonists used for the long run, we need to use add-back therapy with them because you will induce vasomotor symptoms and probably, which is what the patient's most concerned about. And from a long-term perspective, the bone loss is also something that we're concerned about. So you need to think about using some add-back hormone therapy. Some of the regimens we have come with that incorporated into the regimen, and some can be added separately. But very important to use that to alleviate symptoms, the vasomotor symptoms, as well as preserve bone density. There is some data that suggests that short-term use without add-back will actually get you better shrinkage of fibroids. So when bulk symptoms are important, or maybe as a preoperative treatment, very important to have that option to use them without add-back therapy as well.
¿Usted cree que estas moléculas son importantes en la recurrencia de la enfermedad? En el periodo, por ejemplo, en el periodo posterior a una cirugía, hasta tanto la paciente decida un tratamiento en el caso de infertilidad o para evitar la recurrencia de la enfermedad, dado que ambas patologías, los miomas y la endometriosis, tienen una alta tasa de recidiva o recurrencia.
I think so. I mean, for most patients, recurrence levels are quite high. Endometriosis, 50% within 5 years, depending a little bit on age. Of course, if they're perimenopausal, you may not be at quite at the same risk. But for most women, yes, I don't want it to recur. I want to avoid another surgery. I want to preserve their fertility. And I almost always recommend medical therapy after surgery. Now, for those who've responded to an oral contraceptive, that might be enough. But most patients who come to surgery, it's because they failed an oral contraceptive, and I do not recommend them going on an oral contraceptive to try and prevent a disease when they've already failed that therapy. I usually would recommend a GnRH antagonist.
Yes. Por último, ¿cuál cree usted que debería ser desde el punto de vista práctico las medidas que deberían tomar las mujeres en función de prevenir el tema de los tóxicos ambientales, factores epigenéticos, para disminuir los factores de riesgo de desarrollar esta enfermedad?
Yeah, that's still something that we don't have complete clarity on, an active area of research, but there clearly are some environmental factors that play a role. Diet's one of the most important, an anti-inflammatory diet, low-carb diet, probably very effective. There are the metabolic effects of endometriosis that are clear, their effect on adipose tissue, effect on liver, that really can be quite impacted by diet and metabolic factors. So I think that's important. Exercise is beneficial and helps not only with endorphins, pain relief, and mood, which we know women with endometriosis have a higher risk of depression. So the endorphins from exercise are very helpful with that, but there may be some disease-modifying properties of exercise as well.
Por último, ¿usted cree que la inmunoterapia para la endometriosis será una opción terapéutica en el futuro más próximo?
I do think so, but I think it'll be targeted. There's a paradox in endometriosis in that it's an inflammatory condition with a lot of inflammatory cytokines, but yet there's immune protection as well. If the immune system really was working that well, it would destroy the endometriosis. So you both suppress the immune system and activate it differentially at the same time in endometriosis. So we can't just suppress the immune system overall. We may be actually then suppressing some of the defensive mechanisms that are important to prevent the endometriosis from spreading. I think it's going to be targeted immune therapies, really understanding the immune effects and targeting specific immune pathways rather than a blanket immunosuppressant. It won't be just giving the steroids. But again, it's still a lot of research needs to be done before we are certain about which way to go there.
Okay. Thank you so much, Dr. Taylor, for this time.
Thank you.
Thank you.